is no response, then biopsy should be done, which is also required when there is no obvious cause for the leukoplakia. After biopsy, if there is a non-leukoplakia lesion as a diagnosis, then we have to manage it as per whatever diagnosis is there. But if the diagnosis is leukoplakia, then one has to manage according to the degree of dysplasia and the treatment which we provide. Now, leukoplakia habit counseling has to be done, which is priority. And after that, if clinically there is a non-speckled leukoplakia, that means a homogeneous leukoplakia, then the treatment can be started with application of antifungal therapy like nystatin, mycostatin, or candid for 4 to 5 times daily. And observe the lesion. If the lesion shrinks in size, then keep under control. And if the lesion does not shrink in size or it doesn't show any change, then biopsy is required. On biopsy, if there is no tibia, then fine conservative treatment can be given. But if there is severe dysplasia, then surgical treatment with laser or radiation therapy needs to be done. If the lesion is a speckled leukoplakia and if it is a small lesion 1 to 10 millimeter, then excisional biopsy is the perfect treatment. But if the lesion is larger, greater than 10 millimeter, then incisional biopsy has to be done. And after receiving histopathology report, if there is dysplasia, depending on the dysplasia, the further treatment can be provided. So, first is the elimination of etiological factor, followed by a conservative therapy which includes antifungal agent, that is topical clotrimazole 1% or even mycostatin. Vitamin A, that is topical. In topical form it is given isotretinoin 1% or tretinoin 0.05%. And even systemic forms of 13 cis-retinoic acid in the dose of 1.5 to 2 milligram per day body weight can be given for 3 months. Now, most of the white lesions are considered to be superinfected by candida. So, because of the superinfection, the antifungal therapy will have a good action of reducing the keratinization to a certain extent. And vitamin A, which can be given in topical or systemic form, has a triple effect of antioxidant, anti-keratinizing, and immunomodulating. So, in all ways, the lesions could be benefited. And apart from that, even other antioxidant therapy including beta carotene supplementation in 20 to 60 milligram per day, lycopene, which is rich tomato extract, having a very good antioxidant potential, and clinical trials have proven lycopene to be very beneficial in the premalignant lesions, can also be given to these patients in the dose of 4 to 8 milligram weekly. Antioxidant therapy is beneficial as the oxygen species, the free radicals, they have a very detrimental role in at cellular level in promoting the carcinogenesis or promoting the progression of the lesion to malignancy. Therefore, antioxidant therapy has a very good role in preventing that process. Topical bleomycin 1 to 2.5% can be given, and it has shown in studies to reduce the size of leukoplakia. Photodynamic therapy, aminolevulinic acid 10 to 20% have also shown to be effective in regressing the leukoplakia. But if the patient does not show, the lesion does not show any improvement, then there is surgical management also available. That is a conservative surgery with the help of scalpel, the lesion can be removed, or with the help of cryosurgery and laser also the lesion can be removed. And these two therapies have the advantage of minimum bleeding and faster healing. Next is the erythroplakia. Now, erythroplakia, if we see as compared to leukoplakia, it is a completely white, red lesion. Leukoplakia is a complete white lesion. Erythroplakia is a complete red lesion. So, it is any lesion of the oral mucosa that presents a bright red velvety plaque, which cannot be characterized clinically or pathologically as any other recognizable condition, nor traumatic, vascular, or inflammatory. And the prevalence of erythroplakia is very less. It is 0.02 to 0.83%, is that rare. The etiology is most of the time unknown with idiopathic. Alcohol and smoking can act as predisposing factors. Tobacco chewing is a major risk factor in erythroplakia also. And undoubtedly, Candida superinfection is always there associated with the oral lesions, and that also increases the chances of dysplasia. The clinical features is that erythroplakia is commonly seen in 6 to 7 decades of life. Males are more involved, and half of the cases are on the vermilion border of the lip, that is the most sensitive area. Whereas the other areas like soft palate, buccal mucosa, floor of the mouth, and tongue can also be there, can also be affected. And erythroplakia is just an asymptomatic lesion like lipoplakia, but in few patients it can have a burning sensation, and the appearance is red velvety macule with well demarcated borders, and it may be speckled with white spots. So if you remember the images of speckled lipoplakia which you saw in lipoplakia, that similar appearance can be there for the erythroplakia having interspersed white spot called as a speckled appearance. And the malignant potential of erythroplakia is very high. It is 14 to 50%. These are the clinical variants. This is a homogeneous form of erythroplakia where complete red area is there, and you can see it is well demarcated. This is in the second figure we can see a homogeneous erythroplakia with a white component in between. So it can be called as a granular or speckled form, which is seen on the lateral border of the tongue. This is erythroleukoplakia on the tongue, the third image, which is showing a mixed red and white lesion. The white component is very hyperkeratotic, but it also has a red component in between. This is another example of erythroplakia involving the dorsum of the tongue. You see most of the part of the tongue is also depapillated, but on that depapillated tongue there is a well-defined red area, which is an erythroplakia. Investigations which can be done for erythroplakia, they are very similar to the leukoplakia, that is toluidine blue staining. You can see in the first image there is a lesion. After application of the stain and washing it by the acetic acid, the entire area has retained the stain. So possibility that this entire lesion has dysplastic changes. So histopathological examination, various grades of dysplasia could be available, from carcinoma in situ, that is all the dysplastic lesions contained in the epithelium up to the basement membrane and there is no break of the basement membrane, or it can be a squamous cell carcinoma in which the basement break is there and the dysplastic cells, they penetrate deep into the connective tissue going towards the blood vessels. The differential diagnosis. Now, the first one is the chemical or thermal erythematous macule, uh, in which the ulceration or stripping of the mucosa, and it can blanch on pressure. Now, chemical or thermal erythematous macule, the patient will typically give you history of exposure to a chemical or a uh, thermal agent, hot agent, because of which the patient had that ulceration or stripping of the mucosa, which will not be there in case of erythroplakia. Next is the traumatic erythema. Again, in this patient will give you the history of trauma. Next is purpuric macule, which can be seen in patients, those who have a history of trauma, which later becomes blue, and it is a poorly demarcated lesion as compared to erythroplakia, which has a very well demarcated periphery. The dentist stomatitis, it will be present on the palate in the denture bearing area, so it can be easily the area can be demarcated along with the presence of this denture. Histoplasmosis, candidiasis, these are the fungal infections which can be present in the patient, and the appearance can be from a reddish area to pseudomembranous area to an ulcerative area in cases like histoplasmosis. So again, if adequate investigations are done, like the fungal culture or biopsy. The presence of hyphae and all will help in differentiating these fungal infections from erythroplakia. And macular hemangioma can be present in the oral on the oral mucosa, and typically macular hemangioma will blanch on pressure, which is not a feature seen in the erythroplakia. These are the examples. This is a chemical or thermal erythematous macule, which you can see over here. So history of exposure to a chemical or thermal agent will help in differentiating it. This is a papular macule, purpuric macule on the palate. Common site is the palate. This is denture stomatitis. See, the outline of the denture outlines the denture stomatitis lesion. And this is an example of histoplasmosis, where you can see the red areas are associated with uh, a bit of hyperplastic or ulcerative area. So management is basically removal of the cause. If we remove the cause, like the patient is having tobacco, alcohol, or any other things, so counseling and de-addiction is required. Medicinal therapy can include antioxidants like vitamin A, C, E, carotenes, or lycopene. Photodynamic therapy, like we had given it for leukoplakia, same can be given for the erythroplakia as well if the lesion is smaller in size and having minimum dysplastic changes. Surgical management like surgical stripping, laser ablation and cryosurgery can also be tried. But if the lesions are invasive, then the protocol for malignancy management should be followed. Adequate imaging is required for knowing the extent of metastasis. Basically, we need a 3D imaging in which the extent of the local lesion as well as the metastasis both will be identified, and accordingly surgical planning is to be done. And if required, the patient can also be kept on chemotherapy or radiation therapy. Regular follow-up with proper investigations is required for each and every patient. So summarizing, we can see that leukoplakia and erythroplakia both are pre-malignant lesions. Both of them are different entities having similar etiological factors. Therefore, the need to identify the etiology, remove the etiology, adequate investigations needs to be done, after which the treatment can be planned and patient should be kept on regular follow-up for further treatment follow-up as well as further recurrence. The expected questions are the define the pre-malignant lesions and conditions, enumerate potentially malignant lesions and conditions, write about the types of leukoplakia. All these carry 3 marks, whereas the 10 marks question include describe in detail etiology, clinical features, and management of oral leukoplakia, or describe in detail clinical features, etiology, and management of oral leukoplakia. So both can come for